Hi, everyone. Welcome and thank you for joining us for the first episode of 2022 of Chang Reaction. My name is Taylor Young, and I am the Assistant Director of the National Keratoconus Foundation. We are a patient advocacy program based in Southern California at the University of California, Irvine. NKCF provides information to patients and their families and raises public awareness of this cornea disease. We invite you to visit our website, nkcf.org, and sign up for our newsletter and to register for our bi-monthly webinars. We also post news on our LinkedIn, Instagram, and Facebook pages. This is episode 10 of Chang Reaction, our Ask the Expert podcast. Our partner is Dr. Clark Chang, a noted keratoconus expert and friend of NKCF. We often receive questions about life with keratoconus, and Dr. Chang has offered to share his advice on these questions. NKCF records and archives these episodes for the public. You can view past episodes by going to nkcf.org/webinars. Dr. Chang is currently the Director of Specialty Contact Lenses on the Cornea Service at Wills Eye Hospital in Philadelphia. He is also a member of the Medical Affairs team at Glaukos, which is the company that makes the FDA-approved crosslinking product and equipment. He is a graduate of the Pennsylvania College of Optometry and a fellow of the American Academy of Optometry. Dr. Chang was also named the NKCF Top Doc in 2020. Hello, Dr. Chang.
Hello, Taylor. Hello, everybody listening. How are you doing today, Taylor?
I'm doing really well. We got a lot of good questions that I'm excited for us to talk about. And yeah, I just love all the new questions we're getting in. So everyone keep sending in your questions so that we can keep these episodes going.
Oh, I couldn't agree more, Taylor.
Okay.
I know that you've selected a fresh list of all the questions that people have submitted into us. And I'm just so glad that, that we have so many followers and listeners who are participating in this with us. So thank you all very much for doing this. I love answering your questions. So I'm ready to go, Taylor.
Okay, wonderful. So our first question comes from Mike in New Jersey. He asked, last month you mentioned a lot of possible treatments. Is there any possible treatments for people who had a cornea transplant over 30 years ago, for example?
Okay. Interesting. So hello, Michael. The answer is yes, but keep in mind that both Dr. Greenstein and I discussed many investigational procedures last episode that are not yet FDA approved. So we sort of pipeline what's coming down in the future that's available for patients again in the future. And so let me at least tell you what I think could be a possible treatment option out of all the myriads of treatments investigational treatments that we talked about that would be applicable for patients with a corneal transplant. So while many of us in clinic estimate a lifespan of each corneal transplant to be approximately 15 to 20 years, obviously that's not carved in stone, because some people do a lot better, such as yourself, where transplants sometimes can last a lot longer than we expected. But regardless, having that sort of estimation of lifespan to a transplanted tissue still means that many patients will need to receive a new corneal transplant after a certain period of time has gone by. And so, it's important to know what other options are out there. Obviously, one of the options, would be receiving a new corneal transplant. Another option sometimes is I take care of a lot of these patients who still need contact lenses after a corneal transplant, and I often have to alter my fitting approaches. So I don't fit every eye the same. So I have to alter my fitting approaches to try to be able to in the hope to preserve or to maximize the viability of the corneal transplant underneath the contact lens. So those are some of the sort of current approaches. But the question really still remains, if we always, do we always have to do a complete or full thickness corneal transplant the second time after the first time, after the first one fails? And so this is where some of that new investigational treatment options that we talked about last time could apply. And that those of you who didn't, get a chance to catch the episode with Dr. Stephen Greenstein, please feel free to click on episode 9. But many of you will recall that we discussed, one of the options we discussed was injecting stem cells within the cornea to help strengthen and reshape the keratoconic cornea. So there's a similar technique like that, utilizing cell injection therapy inside of the eye, not in the cornea now, we're injecting cells inside of the eye that may actually, I think in my mind, have in the future be able to help a failed corneal transplant after a long period of time. So how does that work? Very quickly, in many cases, understand that a corneal transplant fails after say 10, 15, 20 plus years. One of the primary reason is that the endothelial cell, which is the very back layer of the corneal transplant, is no longer working. But the viability of the cells in front of it, all the other layers in front of that endothelial cell, may actually still be healthy. So if that's the case, it is possible to, in the current approach, to just transplant the very thin back layer called endothelial cells. And so what the injection therapy can do is to try to kind of overcome the donor availability issue, right? Because right now we have one donor that donates one corneal tissue and only benefits, one endothelial cell layers can be harvested and only benefit one patient with a failed graft. But this new cell regeneration biotechnology technique that started in Japan can actually use different cultural passages, grow this one harvest of endothelial cell into many different culture copies. Think of it as almost like cloning, but in this case, we're growing them in a culture. And then the cells can be stored in an injectable ophthalmic solution so that they're ready to go as long as they're carefully stored. And then these endothelial cells, once injected into the eye, can eventually fill in on the layer that is no longer working. And so that is one possibility that I think in the future can help with corneal transplant that has gone for a long time, that now may require a second transplant as long as it's just the back layer that's the issue. And this new technology is being prepared in Japan for review at their national regulatory agency, but has just begun entering clinical trials in US. So something to for us to watch out for this space in the future. So I'm really excited about that.
Wow, that sounds really exciting and interesting. I think that's a good thing that patients should know, is that there's always research being done. So hope is not lost if you don't really fall into like a specific category of a approved treatment already. There's hope for the future. So that's wonderful.
Yep, couldn't agree more. And they just have to keep listening. We'll keep updating them, Taylor, right?
Yep, exactly. Well, our next question comes from Sean. Sean says he's 30 years old and his current right eye micron is 465. A year ago, it was 470. Should he proceed with the crosslinking for his right eye? His right eye is blurry and he cannot see small letters with the right eye.
Right. Good question. Hi, Sean. So for this question, it's not a definitive answer by me. So I'm going to give it a maybe. It is possible that you may need FDA-approved corneal cross-linking as you're asking, but probably not for the clinical reason that you cited. So taking a step back, micron is the unit that we measure the thickness of your corneal tissue. And so what did I mean when I say maybe to Sean? For those of you out there listening to this question, and I'm sure many of you have similar questions like Sean is asking. So the primary purpose of the FDA-approved corneal cross-linking is to slow or stop or halt progressive keratoconus. So when the progressive keratoconus can be slowed down or stabilized, then hopefully we can greatly defer the need for corneal transplantation, such as the question that I just answered from Mike. So this is really a very important question because, like I said, a lot of people are probably thinking about the same thing or planning for future about what should I do if something is still continue to change with my keratoconus cornea and my vision. So we need to really understand what actually is progression. And while there's not in keratoconus, what is progression in keratoconus? And while there's not an absolute consensus clinically amongst specialists and clinicians, there are a few standardized criteria to determine keratoconus progression that are pretty universal. But sometimes will differ depending on, say, clinical perspective, like I would when I'm monitoring my patients, or maybe insurance, reimbursement perspective, because that may be important. You have to hit a certain criteria for your procedure, the FDA-approved cross-linking to be covered. So if you're more wondering about, the insurance perspective, you could look up livingwithkeratoconus.com, which can add a link in the comment section for you, or the description section of the video, may give you some insights in terms of how your exact policy and your insurance carrier determines progression. And NKCF webpage also have some of these insurance related information as well that I would encourage you to look up. I know Taylor works very hard at keeping that section very insightful for you. But coming back to my point of what clinical criteria, what are some of the more standardized one for keratoconus progression? A thinning of 5 micron, which is what you said, right? A year ago, you're 470. Right now, you're 465 micron thickness. That thinning of 5 micron at the thinnest point of your cornea over 12 months period of time is actually not typically considered as a clinical marker for significant keratoconus progression or definitive keratoconus progression. And so that's not to say that you don't need treatment and that you're not progressing. It just may be worth your time and your doctor's attention to compare over a slightly longer period of time. Maybe you want to go back a little sooner so that you could compare over 18 months or 24 months. So you definitely should keep in mind that you should consult your eye doctor in terms of how often you should be watched. And then also keeping in mind that keratoconus progression is not just about how much thinning you have over time. Of course, you have a lot of thinning. That's a definitive sign of progression. But you could still have very meaningful progression with a little bit of thinning. What do I mean by that? Because progression can also define by how much change we're seeing in the corneal shape, for example, both at the front part of the cornea and the back part of the cornea. The shape and the elevation data of those two different layers can actually give us a sense of how much progression that is occurring beyond just how much thinning. And also another aspect clinically may be what kind of change is or are occurring with your glasses or contact lens prescriptions, as well as how your vision is declining on the vision chart, among many other things. So there are many different criteria that can actually, and sometimes a combination of those factors can actually produce a more sensitive guideline of how much progression is actually occurring. So again, very important to consult your eye doctors about other testing results. Should you go back a little sooner so that you could compare over a slightly longer period of time, longer than the 12 months that you're talking about? And what other objective and subjective clinical tests does your eye doctor and surgeon want to monitor? So make sure that you do reach out to them, him or the team of doctors who are taking care of you, and make sure that you get a more holistic view about your keratoconus and whether it's really progressing or is it relatively stable. So I hope that helps you to know where to start next, and definitely seek the opinion of your surgeons and eye doctors in terms of how frequent you should be watched and where you should go from there in terms of that 1 year finding that you just described.
Great answer. I think that's wonderful. Well, our last question comes from Marlene in Florida, who asks, when doing measurements for upcoming cataract surgery, I learned for the first time that I have keratoconus. I am wondering how the surgery will affect it. I had surgery when I was 8.5 years old to correct a weak muscle, and all was done that was possible then. I guess that's just some back info on that.
Right, I see. So hello, Marlene. I will say right off the bat that the eye muscle surgery that you had to correct the orientation of the eye when you are at 8.5 years old likely would have no correlation to keratoconus. You don't have to worry about that part being associated. And I definitely understand why, how it could be shocking to be all of a sudden given a new diagnosis when you are, just seeking care for a completely different aspect of your eye. So I do understand that. And oftentimes I kind of want to, in case you're wondering, hey, how come I've never been given this diagnosis up to this point? I want to say that this is a backstory that Taylor and I and NKCF team members have heard a lot. And a lot of times it's just because it helps to have access to special clinical instruments to best diagnose keratoconus. And one of the instruments is called a corneal tomography or topography that analyzes the shape that I had just mentioned in the last question by Sean, the curvature of the front and back of the eye, as well as back of the cornea, as well as the elevations. Those can be measured by special instruments called tomography or topography. And sometimes, and they happens to also help to guide cataract surgery planning. So it's probably one of the few times you had that special test, and that is the reason why you had that done during your cataract consultation, and that's how they were able to give you that diagnosis. But the good news, though, I will give you, if there's one, the silver lining is, if you had just been diagnosed because you're ready for cataract surgery, and you never really, from the sound of it in your history, you never really knew that your vision was hindered or impaired. So that then tells me that you likely have a very mild or maybe a very even preclinical form of keratoconus. So that bodes well for you. And let me explain why I said that. So generally, we expect that most of the keratoconus patients to be stable or relatively stable when they're getting ready for cataract surgery, because their keratoconus is much more likely to get worse very, very quickly earlier in life when they're diagnosed earlier in life. And so, again, as I said, you likely then have a very mild form of it if it never affected your vision or you were never diagnosed. And that if your surgeon or eye doctor is now questioning whether or not your keratoconus is actually progressive, they will first check to make sure that's stable before they will perform the cataract surgery, so that it will reduce the impact to cataract surgery as much as possible. But again, like I said, the fact that you probably, based on my assumption, have a very early, even possibly preclinical form of keratoconus means that because you didn't have the visual symptom, don't have the history, and not in your family members with keratoconus. So if all my assumptions are correct, then the silver lining here is that you have a very good chance to have much better cataract surgery outcome compared to people who actually have more definitive or advanced form of keratoconus. So really, it's not so much how does keratoconus surgery affect your how does cataract surgery affect your keratoconus, but it's more how does keratoconus affect your cataract surgery outcome. So, which is your question? Because most of the time I receive the other end of the question that I just verbalized. So in terms of how does keratoconus affect your cataract surgery, there are usually two direct areas that are more impacted. Number one, during cataract surgery procedure, we make small incisions in order to be able to insert an artificial lens into the eye with pre-calculated power so that it'll help you see better after cataract surgery. With keratoconus and the shape of the keratoconus being much more irregular or warped, that calculation is much more difficult and unpredictable. So it is possible that then after cataract surgery, your vision is not as good as we want you to be or you want to see. Then at that point, we will rely on glasses, but much more typically contact lenses to help you achieve the best distance vision after cataract surgery. So that's number one. Number two, keratoconus can also affect you in a way that the incisions don't seal as well because the cornea tissue, they're a little weaker, they're more likely to swell after the surgery, so they don't form a seal as well as they should compared to no keratoconus. And so sometimes we'll oftentimes actually will just put an extra suture around those incision site temporarily until they really prove that they have a good seal and nothing's leaking out before we release the suture. So that would be a slight modification to the surgical technique. And so I hope that that helps you. And obviously feel free to talk to your surgeon, your eye doctor about if you should be watched for a little bit of time and determine stability prior to cataract surgery. But it sounds to me like you're probably, like I said, have a very early form or are relatively stable. And therefore you should have very little impact by keratoconus to your cataract surgery, but definitely worth checking it out with your surgeon and eye doctors.
Wonderful. Well, that's all the questions we have for this month. So thank you again, Dr. Chang, for guiding us through these questions. Next month, everyone should look out for another Chang Reaction episode. Again, they come out on the 1st of every month, so you can rely on that.
Yes.
About
oh, and
all
Taylor,
your
let me say
answers.
one more thing to Marlene. I'm sorry, I forgot to say. And of course, please fly us back to let us know how you did after your cataract surgery. We would always be happy to know how you did. So sorry for the interjection.
No
Go
problem.
ahead.
We love the updates after people
Yeah.
get their advice. So that's wonderful. If anyone listening has a question that they would like answered in a future episode, please go to the NKCF website, and under the For Patients tab, you will find the Ask the Expert Chang Reaction. You can post your question there and we'll try to answer it during an upcoming episode. NKCF operates with the support of friends and donors. If you feel the urge to support us, you can make a much appreciated online gift to the UCI Foundation. In closing, I just want to again thank Dr. Clark Chang for taking the time to work with us each and every month to answer our listener questions. We really appreciate it.
Thank you, Taylor. And again, I really appreciate patients trusting us and sending in questions. So please do so. And I will see everybody at our next episode.